welcome to what promises to be another interesting edition of Hot Issues. Within the last few days, we've had reports of the outbreak of 3 strands of meningitis in Ghana. What are we doing about it? Are we sure of the figures? To what extent is the international community collaborating with our health authorities to deal with the problem? Welcome to Hello, welcome back to Hot Issues. And as I indicated, this promises to be another very interesting edition of the program. We are looking at the outbreak of 3 strands of meningitis in parts of the country, reportedly the 3 northern regions, parts of Bampoe and Ashanti. What is the extent? Are we sure of the numbers? What are the numbers? What are we doing about the problem? And to what extent is the international community assisting us to deal with this health problem? And we are privileged to have with us in the studio the Deputy Minister of Health, who is himself a medical doctor, in fact a public health practitioner, and indeed it's involved in the Global Fund for dealing with such cases, Dr. Victor Bampoe. Sir, you're welcome to the studio.
Thank you very much.
First of all, what is the situation like? Is it true that we have this outbreak of meningitis? Is it true that there are 3 strands? And what is the situation like?
Thank you very much, Kwesi, for having me. It is true that we have an outbreak of meningitis, but we've had meningitis in this country since 1900, and if you'll allow me, I'll go into it a little bit. Meningitis is actually derived from a Greek word, meninx, which means the membrane, and itis, which means swelling or inflammation. So it's an inflammation or a swelling of the membrane that covers the brain and the spinal cord. So because of the proximity of this membrane to the brain and the spinal cord, when there's an inflammation, it's a medical emergency. And very often in the past, before antibiotics, it very often meant a death sentence. Things have changed very much since then. Now, in Ghana, like I said, we've had this since 1900. And in 1900, the British brought some East African laborers to help to fight against the Ashantis. And they had an outbreak of meningitis, a small outbreak in Cape Coast. Then the first African epidemic was in what was then Gold Coast and Nigeria, 1905, 1906, where about 18,000 Gold Coasters had meningitis. So it's something that has been happening over year in, year out. And if you go to the 3 northern regions, around October to March, when it's very dry and dusty, and I'll explain the relationship with the environment. When it's very dry and dusty, you know, between October and March, they know that it's the meningitis season. So health workers work very hard to try and pick up the cases. Because of this, in 2012, the Ministry of Health did a massive vaccination exercise in the 3 northern regions. So whereas, for example, in 2010, we were having 1,100 cases and about 128 deaths, by 2015, we were down to about 439 cases with 44 deaths. Now, every death is avoidable, but this is much better than what was happening in the past. So coming to the current situation, why are we concerned? We're concerned because 2 things happened. The 3 northern regions are in what we call the meningitis belt, which is 15 countries that run from Senegal in the west to Ethiopia in the east. So if there's meningitis there, it's caused by one particular strain or strand. And you know, we know that it will happen. This time the focus was in 2 communities in Tain district in Brong-Ahafo, Brohani and Sekwa. And the organism was also different. So what then happened was that in medicine, in the practice of medicine, there's a common saying. They say common things are common. So health workers in Brong-Ahafo were not used to seeing meningitis, you know. So they were diagnosing it, especially the health workers in the periphery, diagnosing it as malaria. So the cases that were coming to the health facilities and being discovered as meningitis were being picked up late. And one of the things about meningitis is that if you don't pick it up early, then the prognosis is rather poor. That's why we've had those deaths. So yes, it's an issue of concern because it's moved out of its normal zone for climate change reasons, because there were some vaccinations in the past which has made one other strain, you know, take over when another came down. And that's where we are right now.
Is it true that we have cases in Ashanti?
Yes, we do have cases in Ashanti, but we need to be careful about whether it is related to this outbreak. There again, I'll explain. You know, meningitis is endemic in Ghana, and when we say a disease is endemic, it means that it is found as part of the, you can't call a disease normal, but it's found as one of the normal diseases that occur. And meningitis in Ghana is something that, you know, we see once in a while. It is one particular strain. It is the meningococcus strain. So if you see meningitis in Ashanti, in and of itself is not an issue. Why I'm saying we should be careful is that because there's an outbreak in Brong Ahafo, the tendency is for the sporadic cases to be automatically linked. But what is causing the meningitis in Ashanti is a different strain from what is causing the meningitis in Brong Ahafo. So technically speaking, the two are not linked. Does this matter to the ordinary person on the street? No, because they know meningitis is meningitis. But for the medical people who have to deal with it, then it's very important. It's very important because depending on what strain is causing the outbreak, the responses can be different. So yes, there have been some cases in Ashanti. In fact, I think there are 12 cases. 8 of them have died in Offensu and a few other districts. But it's not related to this current outbreak, which is in 18 districts out of the 27 in the Brong Ahafo region.
Now, when we talk about 3 strands of the disease, what exactly are we talking about?
All right. So meningitis is normally caused by either fungi, or it can be caused by bacteria or viruses. What is of concern to us here in Ghana is what is caused by the bacteria. And there are 3 kinds of bacteria that cause meningitis. So what we've come to know as the cerebrospinal meningitis, or CSM, is caused by a bacterium called Neisseria meningitidis. Now, what is currently causing the epidemic in Brong Ahafo region is a different one. It's called Streptococcus pneumonia. So it is the same organism that causes pneumonia. But what happens is that when the climatic conditions are different and the conditions within the human body are favorable, then it can go into the space that I described earlier and then cause meningitis. So for our purposes, what we are worried about are the bacterial meningitis, and that is what causes the problems for us.
All these 3 strands, we just discussed 2, are the 3 strands present in Ghana?
Yes, the last one is called Haemophilus influenza. That one is not very common, not only in Ghana, but it's not very common. Interestingly, we have vaccines for the 3 of them. So like I said, for the first one, the CSM, the meningococcus, there's a vaccine that was applied in 2012. You remember I said that it was applied in 2012. So we have a vaccine for that. The second one, which is now causing the challenge in Brong Ahafo, we have a vaccine for children as part of our routine vaccines that we give to children. There are 13 routine vaccines. And this vaccine for the pneumococcus is also given to our children. So there's a vaccine for that. And then the third one, like I said, is the Haemophilus influenza, which is not very common.
But has it occurred?
Haemophilus influenza has occurred because it's one of those ones that can occur sporadically. So it's not uncommon for a doctor to see a kid with Haemophilus influenza meningitis. But because there is a vaccination against it as part of the routine vaccinations of children, then it's not something that you would see very often. Because in Ghana, our vaccination coverage is quite high.
But are we seeing it now as part of the general outbreak this time?
No, we are not.
We are not.
No.
So we are only seeing two strands.
We are seeing, yes, we are seeing two strands. We are seeing the pneumococcus and we are seeing the meningococcus. But with the meningococcus, there are also substrands. Not to make it too complicated, but in the meningococcus, we are seeing one that is called W135, and then we're seeing, in some places, we're seeing a meningococcus C. You know, so
what difference does that make? I mean, in terms of containing the outbreak, in terms of treating the disease, does it make any difference?
That's a very interesting question. It does make a difference. For example, with the pneumococcus, there are 90 subtypes.
90?
Yes. And we have the vaccine that is in current use, that we commonly use, covers 13 of those. So as part of our response mechanism, we are doing the serotyping, what we call the serotyping, to determine what subtypes that are causing the disease, because that will then determine how we respond to it. If you have a vaccine that does not cover what is causing the disease, then to all intents and purposes, you know, you're throwing your money away.
Mm. So how do we then deal with the more than 70 types that we don't have vaccines for?
Well, it depends, like I said, on what is causing the disease. In Brong Ahafo, because it is a relatively new disease, then in the beginning you find that they come in late. But once the health care workers catch on that meningitis is in the system, as it were, then the diagnosis is much quicker. When you come to hospital quicker, then it is relatively easier to deal with it. When you give antibiotics, they get better. So the focus is on active case searching, giving public education to let people know that when you display the symptoms and signs, you should come to the health facility early so that it can be treated very quickly. Now, some people have asked that if there is a vaccine, then why don't we do what we call the reactive vaccination? We are responding at different levels, and I'll go to the third level, which is with our international partners. We have the World Health Organization present in country, and we've been having discussions with them. In fact, as we speak now, there's a World Health Organization team up in Brong Ahafo region doing an assessment. I was there myself 2 weeks ago, and members of the senior members from the Ghana Health Service surveillance team were also there last week. So, and then we are dealing with WHO at the Africa regional level, and as we speak now as well, our Director of Public Health from the Ghana Health Service is having discussions with WHO in Geneva at the global level. So they are giving us advice that if you look at the cost-benefit analysis, then the best thing to do is what I described, the active case searching and then treating the cases. The vaccines can come in if it makes sense in terms of the amount you spend on the vaccine and how many people it will cover. So there's always that kind of comparison, which would make the best economic sense, which would save the most people. And at this present time, looking out for the cases and making sure we snuff it out quickly will do the trick. Because, like I said, if the health workers know about the disease and they diagnose it more quickly, they will catch it all, and we are hopeful that we'll be able to snuff it out very quickly.
Two approaches, preventive and curative. Can we do one without the other, or we need to couple both approaches?
It's very important that we couple both approaches. And that's how we've dealt with meningitis, you know, all these years. And that's why it's come down to the level that it has come down. Granted that what was causing meningitis in the 3 northern regions is a different organism, but it was the same approach. One approach was to vaccinate people. The other approach was to educate the health workers so that they can we increase their index of suspicion. So if you go to the northern region or the upper east or upper west region right now, between October and March, if someone comes with a headache with neck stiffness and fever, they will think about meningitis before they think about malaria. Because there's an adage in medicine that says common things are common. So once we get that also, going, letting all the health workers know, they'll pick it up very quickly. So they're curing it quickly. It means that the reservoir that would keep the disease going would be reduced. At the same time, you're preventing new cases from coming in. So the two of them will work in tandem. At the current time, though, the pneumococcus that we have in BA, there's not an indication for the vaccination. So we are doing more of the curative side.
Are you considering nationwide vaccination, given the spread? It's in 5 regions out of 10.
Yes.
And it could come down.
I think we must be careful the way we describe the spread. And like I said, it's endemic, so it's not unusual. Though it's not desirable, it's not unusual to find sporadic cases. And so sporadic cases are not an indication for us to have a nationwide vaccination. In fact, sometimes that is contraindicated. We work with several international groups that give us advice. For example, with immunization, there's an advisory committee on immunization practices, and there's an international reference group. The reference group we are in discussion with right now, our Director of Public Health of the Ghana Health Service, looking at all the parameters. Number one, it's going to be very expensive. Number two, sometimes because you don't cover all the serotypes, you don't achieve anything. Number three, sometimes it can make people feel falsely confident that they are covered when they are not. Once you have a good surveillance system in place, that picks up the cases very quickly. That is the way to go, so that you get it quickly, you diagnose it quickly, and your health system works to snuff it out.
What have been the fatalities, the rate of fatality?
It's rapidly changing, so it's something that I'm reluctant to talk about, not because I don't want to share the numbers, but because maybe by the time we finish speaking about this, the numbers would have changed. But I'll give you an indication. In Brong Ahafo region, like I said, there are 18 districts have been affected out of the 27 districts. And we have 195 cases, and we have had 36 deaths.
In Brong Ahafo alone?
Yes. In Ashanti region, we've had 12 cases, and we've had 8 deaths. And every death is avoidable. We wish that we could prevent every single death. But if you compare the 2015 figures for Ashanti region, then in 2015, the number of deaths were the same in Ashanti region as the deaths that have occurred right now. So it's important for us to interpret the figures properly. In public health practice, when it comes to meningitis, the numbers are important, but what is more important is what they call the alert levels and the epidemic levels. So there are thresholds. For a normal district in Ghana, which may have 100,000 people, when you have 10 new cases a week, then you begin to worry. If you have 4 or 5 new cases over 6 weeks, and every week you have 4 or 5 new cases, it's something that you worry about, but you don't worry about it so much, because even though when you add them together, it looks like there are a lot of cases per week, it doesn't reach the epidemic threshold. So the response depends on how we interpret the spread.
You've given us a figure for Brong Ahafo and Ashanti. What about Upper East, Upper West, and Northern? Yes,
I have those figures, but like I said, we don't want to focus on the numbers. I can tell you, for example, that in Upper East there are 22 cases, and I think 7 of them have passed, which is very unfortunate. But like I said, in 2015, nationwide we had 439 cases with 44 deaths. So it's something that occurs. And if you look at the organisms, then some of the organisms causing some of the deaths are things that we see normally, over the years. So we don't want to then add it onto the Brong Ahafo. Yes, we have a challenge in Brong Ahafo and we have to deal with it, but they are not necessarily adding on to what is happening in the other areas to, come up to a big epidemic that should cause alarm. It should cause concern, and there are steps that we are taking. Number one, to advise and to give public education to the communities, to the health workers, and there's advice that we are getting from the international community to help us to deal with it. But if I may, I would like to tell you what the districts and the regions have done so far. So when it was discovered in Brong Ahafo region in December 2015, what the district, Tain district, did was, and that has been replicated in many of the districts, in fact all the affected districts in Brong Ahafo, they got together what they call their district epidemic management team, which consists of their district health management team, their DCE and other officials. And they quickly started planning how to provide public education. This disease comes about because when the conditions are dry and dusty, then it is transmitted via air droplets from one person to another. What happens in the northern part of Ghana is that when there's the Harmattan between October and March, it becomes very cold in the evenings. People shut their windows and they huddle together or they sleep, So that gives the opportunity for this organism to be transmitted by air droplets from one person to another. So the advice is to try and make sure that we have aeration, to make sure that we practice cough etiquette. Mm-hmm. Because one of the ways that it is transmitted is by coughing, by sneezing, by kissing. Interestingly, even though it's contagious, it is not that contagious. So if I had meningitis, pneumococcal meningitis, for example, and I left this room, the chances that you pick it up because I've been here are very small. But if I cough, within a 1 meter distance, or, I sneeze on you, then the chances are increased. So these are the kinds of messages that we're giving to people. It's also very important that when you have the signs and symptoms, you have a headache, neck stiffness, a fever, go to the nearest health facility to make sure that it is dealt with. So that is on the community side. What they also did for those health workers in the health facilities, the affected areas, was to quickly reorient them with the signs and symptoms, the case definition, to make sure that they are very much aware of how meningitis presents, how it is managed, and if it's over and above your competence, then you have to move it on. So that's at the district and regional levels. And we found that all the districts were doing same. At the national level, we quickly, the Minister of Health quickly made sure that the affected district had some funding to support all these activities, the surveillance, the public education. And we also mobilized some medication, and we sent it to the affected districts.
Well, hello and welcome back to Hot Issues. And we are having a conversation with Dr. Victor Bampoe, Deputy Minister of Health, and also public health practitioner. Now, sir, is there a substantial difference between alarm and concern?
I think there is, and I'll tell you why. Meningitis is a disease that actually evokes a lot of fear. So the management must be very sophisticated. The first epidemic of meningitis was in 1806 in Geneva. And I used to live in Geneva, so I remember going to where we call the Old Town in Geneva and seeing plaques which described how the disease came about at that time. Now, at that time, to have meningitis was practically a death sentence until the early 20th century when penicillin and the sulfonamides were discovered. Then there was a better chance. Now we have many more sophisticated drugs. But that has carried through. So once you mention meningitis, the default position is one of alarm. And the worry about alarm is that it can cause some disproportionate reaction that will not be helpful to managing the disease. It is also important to put out the information because you don't also want to hide it from the public and pretend that there is not a problem, because then you have the opposite effect. So yes, there should be concern, and concern means that you are sufficiently aware of the issue so that you take the necessary steps to deal with it. Alarm in my books would be where the response is disproportionate and unhelpful, and I would equate it to the alarm that was caused by Ebola, where it meant that people were running away instead of coming to health facilities. And in the case of Ebola, you would find that in Sierra Leone and in other places, health workers were attacked, some were killed. You know, so it's the way the way we respond to it should be measured and based on the science and the evidence and history.
Is it possible that the outbreak will go beyond the 5 regions? Is it possible? Theoretically, is it possible that this outbreak will go beyond the 5 regions, Upper East, Upper West, Northern, Brown, Afro, and Ashanti? It
depends. If we're talking about and I don't want to get too technical here, but like I explained earlier, if you look at Ashanti, for example, because what is happening in Ashanti, what is happening in Volta, are different strains from what is happening in Brown, then technically, you know, they are not one and the same outbreak. But let's put that aside. It is possible that what is occurring can occur in regions that don't have it now. The most important thing is that once the country, everybody in the country is sufficiently informed about it, and very soon we'll be heightening their awareness even more. So once they are informed about it and they catch it very early, sometimes a very interesting phenomenon can happen. What will happen is that you would start having people coming in who don't have meningitis but think they have it, and they will be tested as false positives. So the numbers, or the supposed number of cases, can increase. But what we're hoping and working towards is that then the actual cases will decrease because they are being caught earlier and they are being dealt with. And then hopefully sooner rather than later, all the cases will go down. So yes, the short answer to your question is yes, it's possible, but it does not necessarily mean that that is a bad thing. The most important thing is that we respond and respond quickly.
I'm not used to this terminology, false positive. Can you explain? I mean, what is false positive?
False positive is when somebody thinks that they have a certain condition. It also happens in the laboratories, you know, where, but let me stick to, you know, to a condition. So you think that you have, because you're hearing so much about a certain disease, you know, headache, neck stiffness. So you think you have meningitis. Or maybe you go into the clinic, and because the health worker is so much on top of his case definition, he picks up the headache and the neck stiffness, and he thinks that you have meningitis. But maybe you didn't sleep in a good position the night before, so you have a little problem with your neck. So they run the test, and it's, you know, so clinically they might say, okay, he has a meningitis. But normally, you know, doctors and other health workers will have a differential diagnosis. So maybe meningitis to rule out malaria and something else. So they go and do the test, and you don't have meningitis. So then you are moved from the clinical positive to a definitive negative. So
from the suspicion
exactly.
to, you know,
so you're a suspected case, and then you become.
So the suspicion is the false positive.
No, it's when you're checked and you're found to be negative. Then, you know, when you were suspected, you were false positive. Yeah.
Okay. Now, is it preventable? Meningitis, whatever strand, is it preventable?
Yes, it is preventable. If the vaccine exists, then if you take the vaccine, then you'll be covered. If the vaccine exists for the kind of strain that is causing the disease, then you are covered. If you also take the precautionary measures that I talked about, make sure that you are not in places where there's a lot of crowding, not doing excessive touching of people. If someone has the disease and there's contact, then the possibility exists that it will be transmitted to you. If someone coughs on you and so on, or sneezes and, you know, he has the disease or she has the disease. So if you prevent those kinds of things, then yes, it is preventable. Yeah.
But we've had this disease from the history for 166 years in Ghana. How come we're still getting it? If it's preventable, why have we had it for 166 years?
Yes, but you remember I was saying that if you look at the figures, then it's gone down dramatically. So up until 2015, we had gone up from 18,000 that I described in 1905, 1906. We had a very bad epidemic in 1996, 1997, where we had more than 25,000 cases. And we had gotten down to 439 cases. But the raison d'etre of all these organisms is to try and perpetuate themselves. So as we also try to battle them, they are also trying to come up. And because we had done the vaccination, it had come down very much. But we had vaccinated for the one that had been there for all those hundreds of years. And now a new, it's not new in the sense that it's something we've not seen before, but it wasn't prevalent. So now that one has shown up its head. So what we then have to do is to reorganize ourselves quickly. It's shown up its head, but in a different part of the country. So I'm very confident that we can do the things we have to do to make sure that that is also suppressed. But like with any other disease, it's pretty difficult to eradicate it completely, you know.
What makes it that difficult, especially when you're talking about a space of 166 years?
Well, we can go back to malaria, for example, which we've had for millennia, you know, which is still killing 3 million, you know, children every year. It's quite difficult, and you have to use a plethora of strategies to try and bring it down. Thankfully for malaria, with malaria, for example, if you take countries like Eritrea, Zanzibar, they've almost eliminated it, and we are also doing very well. But it doesn't happen overnight. It takes time, it takes strategies, because they are also evolving to try and beat what we're doing. That's why, for example, there's resistance to antibiotics. The antibiotics that were used to fight all these bugs a few years ago or a few decades ago are different from what we're using now, because they also then evolve and then it's not effective anymore. So we also have to keep developing new drugs and so on. So it's sort of a battle that keeps going on.
But with malaria, you do know that a couple of countries have managed to eliminate malaria,
yes,
eradicate it.
Yes.
So it is possible.
Yes, but it's taken millennia. That was the point I was trying to make. Because with malaria, we now even have a vaccine which is about 50% effective. You know, that, I mean, we probably, is one of the things on the cards here that maybe we may be using it here, testing it here. So it's work in progress, and sometimes it doesn't happen, you know, as soon as you want it to, but it can happen.
Cuba used less than 50 years to eradicate malaria.
Yes, and it's also because, you know, Cuba was in a peculiar situation. Some of the countries that you've described, like Zanzibar is an island, Cuba is an island. So it's not easy, but it's relatively more straightforward to do what they've done with the dedication and the will. If you are to do it, for example, in Ghana, you can't do it and end at Elubo or end in Aflao without involving the Côte d'Ivoire and Togolese authorities, respectively. So it becomes a tad more complicated, you know. What
are the research institutions available, you know, which are working on all of this, meningitis, malaria, and so on? And what specifically are they doing about the eradication of these diseases?
Internationally or
Ghana, locally?
They're doing a lot of work. I'll give you an example. I was just speaking to the head of the Noguchi Memorial Institute for Medical Research. They are helping us to do some of the typing, you know, to find out what kind of types that we have. And there's a normal test called the PCR. I was pleasantly surprised to know that they have even a higher level. They're going to do what they call biotyping, which will help us to determine what is causing the disease. When you know what is causing it, then you have a better shot at getting the response. Noguchi is doing a lot. We have our national reference labs. We have one in Kumasi, one in Tamale, one in Accra, of course, which are also helping us to find out what the serotypes, the types that are causing the disease. There's the Kumasi Center for Collaborative Research. We've not spoken to them about this yet, but I think it's time that we came together and not only found out what is causing it, but move along and find out how we can prevent some of these things. It's interesting that you asked this question because of Ebola, this became a topical issue. And the African Union was thinking about setting up a research center because of some of the issues that we have as individual countries in Africa right now. It was decided by the AU that instead of countries going it alone, at the present time we should come together and have an African center of excellence. And I think it's going to be based in Addis Ababa. And so we are working towards a situation and a time when we'll be doing some of these things ourselves.
Of course, this would also tax the various laboratories. We do know that there are laboratories here that have to send samples to South Africa and so on. What is the state of readiness of the various medical laboratories that we have in the country? At the same time when we had Ebola, you remember that Noguchi was doing all the tests. Kumasi Center for Collaborative Research is also fully equipped to do some of these tests. But there's always room for improvement. You know the saying that the only room that doesn't get filled is the room for improvement. So yes, we found that even with this issue, some of the weakest links have been, laboratory services closer to the site. But it's important then to know that those are the challenges so that we can work towards making it better. But we have on the continent, we have some of the best. And Noguchi is a world-class institution. It's about spreading it to the periphery so that it becomes something that is across the country. How long is the journey from attack to mortality?
It depends on how strong the person is before. It depends on which organism it is. But typically, it will take, when you come into contact with the organism, it will take anything from 2 to 10 days to get the disease, and it will take anything from 10 to 14 days for the person to die if the person is not given treatment. Sometimes with the treatment, it would go on and maybe the person is not lucky enough to make it, and so would expire maybe 21 days after or something like that. But the good thing is that when they're given the drugs, and the drugs are working, then you see improvement happen quite rapidly. So after about 10 days, you see that they will be doing quite well. The challenge with the pneumococcal meningitis is that it is more virulent than what we've had in the 3 northern regions over the years. So even though it spreads less rapidly, it causes a bit more havoc. That's why you must catch it early. So sometimes the person would come out and not die, but would have what we call residual effects. So sometimes there could be hearing loss, there could be some kind of cognitive deficits and so on. So the best thing to do is to catch it early so that you don't, first of all, that you survive, and secondly, that when you survive, you have all your senses intact.
Catching it early, doesn't it involve the location of laboratory facilities in the areas, in the areas, where the attacks occur?
It can to a certain extent, but it's more important for the clinician, whoever sees the patient, to make the diagnosis. Because if you don't think about it, you won't diagnose it. If you diagnose it, for example, if I'm working in Dollar Power, which is a community in Bole district, and I see...
What? Dollar Power?
Yes.
You mean dollar as in US
yes,
dollars?
Yes.
And there's a community like that
yes,
in Ghana?
in Bole,
Wow,
yes. So if I see a 10-year-old boy who has a high fever with a headache and neck stiffness, what I would then do, the most important thing is to have, we have a certain test called the Pastorex, but there are various other types. So once I think of meningitis, there's a test that I would do, which is called a lumbar puncture. So You place the patient in the appropriate position, put a needle at the base of the spine and draw out some fluid. You can then test that fluid within your consulting room with the Pastorex and make sure that if it is meningitis, you would be able to tell. And roughly you'll be able to tell which kind of meningitis. And then you can start the clinical treatment right away and deal with the other, going into which subtypes and so on later. Because the antibiotic that is used is essentially the same one. And so you can start the treatment.
Hello and welcome back to Hot Issues. And we are talking to Dr. Victor Bampoe, Deputy Minister of Health and a public health practitioner. Now, sir, you spoke about collaboration with international organizations such as the World Health Organization. Beyond advice, beyond discussion and so on, what else is happening with these international organizations?
Well, they've offered a lot of support, and it goes beyond the World Health Organization. We have organizations like the U.S. Centers for Disease Control. We even have the other development partners like the UK DFID, DANIDA, and so on. They are all playing their own various roles. The WHO is a technical agency, so what they do best is to provide technical advice and some kind of support. So I mentioned this test called the Pastorex. They are the ones who have been providing that. They've also been giving us advice as to whether we should vaccinate. And if, for example, if we qualify for vaccination, the kinds of application that we'll have to make, we'll go through them. They would then direct us as to what to do. They are coordinating the other partners to let the other partners know what kind of support we require. And through them, we will get that support. It happened when Ebola occurred. They were very helpful. They provided their own funds, and then they also got other partners to give them funds, which they then directed onto us. The U.S. Centers for Disease Control, they are also experts in their own field. Technically, they've also provided us with funding. Now going back to Ebola, it was through the U.S. Centers for Disease Control and the U.S. government generally that we set up what we call the Emergency Operations System, which we have in operation now, which is a center where we've set up a system where we can quickly identify some of these epidemics, quickly respond to it, quickly get our partners to come and connect with us so that we know how to respond. So it's not only the Ghana Health Service that is doing this, but we have different organizations like NADMO, we have someone from Noguchi, we have someone from the teaching hospitals, and we sit together so that the collaboration is quicker, the coordination is better, and the response is much more accurate. We have other partners providing various types of support like funding, and each partner is playing their part.
I listened to the Director General of the World Health Organization, and it appears to be focusing a lot more on the outbreak of Zika in Latin America. Isn't that likely to draw world attention from meningitis?
I don't think so. So far, we haven't been denied anything that we require, whether it's from, and I must say that the first port of call when it came to this response was within the Ministry of Health, and then of course the government as a whole. So we've not been lacking anything. With Zika, because it's a new concern, even though Zika itself, the first time that Zika came up, it was in the 1950s. I think in 1950 in the Zika forest in Uganda. And then it went eastwards to Polynesia and so on. And interestingly, it has now come back, and it's in South America and Latin America. But just because it was gone for such a long time, and it's doing something different, it's causing children who are born when their mothers had the disease to have microcephaly or small heads with malformed brains. So it's a relatively new concern that is causing problems. With meningitis, by and large, we know how to deal with it. It's doing it early and having the resources to do it. So I don't think that there's a challenge as such. The most important thing is also that it's very important to rely on ourselves, because If you don't have a health system that is robust, then you will not be able to respond no matter how much support you are given externally. And so that's why it's very good, the kind of health infrastructure that is being put up currently in the 3 northern regions and across the country. Because when you're dealing with healthcare, there are 3 things you must look at: the people, the infrastructure, and the equipment. And I'm glad to say that in all the 3 areas, over the last few years, there have been massive improvement. I was in the 3 northern regions just 2 weeks ago, and the kind of developments that are going on, right from the CHIPS compound level to the teaching hospital level, are phenomenal. More people are being trained. When I came out of medical school in 1993, we had a maximum of 120 doctors being trained every year. Now we have close to 600 doctors every year. Are we where we want
Who
to?
don't stay?
Well, you know, I'll tell you what. When I came out, we were 52 in my class. 48 of them are not with us.
That's the point.
But that was in 1993. Now it's quite different. Now many more stay. And it's because the conditions are getting better for people to stay. And I'll give you one example. If people don't like to serve in the 3 northern regions because they think everything happens in Accra. But when you put a teaching hospital in Tamale, it gives people the encouragement to go there, because when a young doctor comes out, he wants a place where he can train and become even better. If you offer something in Tamale, he trains there. Those are his impressionable formative years. He's probably going to, you know, get the family there, stay there, and then, you know, have his or her roots there. It's difficult for you to get somebody to come and train at Kolebu and say, when you are finished training, you know, go up to Wa or go up to Tamale. So things are happening which are interrelated, which are making people stay much more than they used to stay when I came out of medical school. It also has to do with the equipment that you work with. I was surprised, for example, and pleasantly so, to learn that, you know, they have a functioning magnetic resonance imaging machine in Tamale Hospital. And there's, you know, some procedures. We have people going up to Tamale to carry them out because they have more, quote unquote, competent doctors and better machines. So things are changing rapidly, you know, and you have to have that platform upon which you can then build a better health system.
Now, given the fact that Zika is mosquito-borne, shouldn't we be alarmed? Shouldn't we have concern?
Yes, we should not be alarmed, but we should be concerned. And very shortly, I think in the next day or two, the Ghana Health Service is going to put out an advisory about how we should deal with Zika. Because it started off, this current epidemic started off in Brazil and in Latin and South America, and it's quickly spreading. I understand that there are cases in Canada, there are cases now in Italy. So I'm sure that very soon it will get here. But the expert group is looking at it, and we're thinking about how we'll deal with it. The interesting thing about Zika is that it's spread by a certain mosquito, predominantly spread predominantly by Aedes aegypti mosquito, which is not like the one that spreads malaria. The one that spreads malaria bites in the evening and, you know, during the night. So when you have a mosquito net, you can prevent a bite. Aedes aegypti bites, you know, during the day, the late afternoon and so on. So it makes it a bit more complicated. In and of itself, the disease, Zika, is not a problem. You have a fever, you have a rash and so on, and invariably you recover. It is this issue about causing problems in unborn babies, and, you know, even though it has not, the link is not definitive, there is enough association for people to be worried about it, you know, and that is where the deformities that it causes in children. But we are still working with the WHO, and we're sure that in the shortest possible time, some kind of advice and guidance will come up, and that will help.
Last week I saw an alert issued by the Kenyan immigration authorities about travelers from Ghana with regards to yellow fever. What is the situation?
And there again, that's the difference between the concern and the alarm that I talked about. We did indeed get that information. What happened was that I think in the third quarter of last year, in West Gonja district in the northern region, there were 12 cases of yellow fever and 3 deaths. Now, why had it occurred there? That area is very close to the game reserve, and it has a lot of migrant people. There again, trying to be proactive, the Ghana Health Service and the Ministry of Health had done a massive vaccination exercise. But that area had some people who were itinerant, hunters and so on. So that vaccination exercise did not reach them. So that was the focus from where we had these cases.
Has it been contained?
It
the
has
yellow
been
fever
contained.
outbreak has been contained?
Since those initial cases, we've not had any at all. What we are also doing is that we're doing a reactive vaccination. So 11,000 doses of the yellow fever vaccine were quickly shipped up there. And as we speak now, this vaccination is going on to make sure that we quell it. It's of concern because, the press, the world press picked this up, and then this happened where, Ghanaian travelers and so on were not being allowed to board flights if they didn't have the cards. What we did was then to write an advisory and to write a letter to the Ghana Airports Company, copy to all the airlines, which detailed what had been done, why it's not an issue anymore, and why they should stop, quote-unquote, harassing Ghanaian travelers.
Well, thank you very much, sir.